recording. Ahmed and Hassan, if you can start by introducing yourself, and after that, I'll allow you to share your screen so that you can talk about what you are doing to the students. Okay? Go ahead.
So, thank you. Hello, good morning, everyone. My name is Ahmad Saleh. I am a recent graduate of the Yale School of Public Health, and I'm currently a fourth-year medical student at SUNY Downstate in Brooklyn, and I'm very pleased to be with all of you today.
Hey everyone, my name is Ahsan Abulanin. I'm also a recent graduate from Yale School of Public Health. I'm also now a quality and patient safety consultant in the WHO, the East Mediterranean region. And I'm also heading the research and performance improvement section in the Pediatric Oncology Hospital in Cairo, Egypt. And I'm also one of the co-founders of Make Death Count. Nice to meet you all.
I know this is awkward. I just want to say hi to everybody.
Hi for everybody.
Yeah.
Okay. Okay.
Perfect. Alrighty. So today, just to give you a quick brief overview, we want to tell you about our work within our research that we've done recently, our current work as co-founders of a nonprofit in global health, looking at mortality surveillance, and we really hope to go through our presentation fairly quickly and have some time in the end for Q&A. So I'll go ahead and present our screen. Alrighty.
Alrighty. So
take it away.
Yeah. So hi, everyone. Nice to see you all. I would like to first thank Dr. Rua for inviting us to our class today. So my colleague Ahmed and I will walk you through our experience in developing mortality surveillance in low and middle income countries. Next, please. So during this session, we are aiming to cover the following objectives. First, we will start by explaining the importance and causes of a central registration and vital statistics system, CRVS, in low and middle income countries, and the role of verbal autopsy in gathering causes of death data in countries with incomplete to no mortality surveillance. And that is to lay out a short background before discussing our experience and Make Death Count in developing a mortality surveillance program in a humanitarian crisis region. Next slide, please. So this is the outline of our session today. It's composed of three parts. The first part is CRVS. We will talk about what is it, its importance, application, definition, and challenges. And then our tool for mortality surveillance, which is verbal autopsy. We will discuss its definition, uses, and the list of causes of death that it measures. And then we will dive into our organization, which is Make Death Count, and we will discuss with you, like Ahmed said, our experience with our first project of verbal autopsy in Northwest Syria. Next slide, please. So the first part is the civil registration and vital statistics system. Next, please. So the first part of the CRVS is the civil registration, and it's pertaining to collecting information on the frequency or occurrence of specified and defined vital events, as well as relevant characteristics of the events themselves and the persons concerned. According to the UN, the definition of civil registration, it is the continuous, permanent, compulsory, and universal recording of the occurrence and characteristics of vital events, and that is like birth, death, fetal death, marriages, and divorces, and other civil status events pertaining to the population as provided by decree, law, or regulation in accordance with the legal requirements in each country. So through civil registration, individuals are granted formal legal status, which allows them to access essential services such as healthcare, education, and financial services. Next slide, please. And then comes the second part of the CRVS, which is the vital statistics, and it's concerned with compiling, processing, analyzing, evaluating, presenting, and disseminating these data in statistical form. So as you see here in this diagram, the first step concerned with the civil registration system, which is the collection of information, which will result in civil registry database, and upon evaluation and analysis of the database, it will result in the vital statistics. Next slide, please. So why is it important? Why do we need it? First of all, the good public health decision-making is dependent on reliable and timely data on births and deaths, including causes of death, and that is by understanding how many, where, and what people are dying from, as well as knowing the size and age distribution of the population. And this is important to plan essential services for the population and to know where to allocate resources for health programs. And an example of that is vaccination programs, location most in need for health services, and maternal and child health programs priorities, and so on. Next slide, please. Moreover, CRPS is very important for Sustainable Development Goals, or SDGs, and they are a call to action to end poverty and inequality and protect the planet and ensure that all people enjoy health, justice, and prosperity. In 2015, all the countries in the United Nations adopted the 2030 Agenda for Sustainable Development, and it has 17 goals, including 169 targets and 230 indicators. And CRVS represents a key data source to monitor 12 out of 17 SDGs and 67 out of the 230 SDG indicator. The SDG targets are related to education, economic growth, employment, health, and disability. And in particular, CRVS is central to SDG target number 16.9, which promotes legal identity for all by 2030, including free birth registration. Next slide, please. So some of the application of CRVS besides mortality surveillance, which we are going to discuss in details in part 3, as part of our organizational experience, we would like to provide you with a few information and a snapshot of other very important applications for CRVS, including child protection, human rights, and gender and social equality. Next slide, please. So in 20 countries, children need to have a birth certificate in order to receive vaccination. And in more than 30 countries, birth certificate is required for treatment at health facilities. So children can be made very vulnerable if they lack legal proof of their age. Having proof of age become a tool to protecting against child trafficking and child labor and child marriage. In Philippines, for example, approximately 50% of the cases involving child labor prostitution could not be prosecuted because a birth certificate was not available to prove that the alleged victim was a child. Next slide, please. CRVS is also important to protect human rights in regards to nationality, access to healthcare and education, and voting. In some countries, marriage certificate is needed when registering a child at birth, and having structured marriage, divorce, and death registration helps protect inheritance rights. Next slide, please. Women are often underrepresented in death registration, making it difficult for families to obtain an inheritance and depriving families of assets. And another example is in Uganda. National surveys estimated that fewer than a third of children under the age of 5 and less than a quarter of deaths are registered with civil authorities, with the lowest rate seen among poor and rural respondents. And this failure to register complete and representable data of all segments of the society creates what's called an invisible population. And that is magnifies an already stark inequality between the rich and the poor, the rural and the urban. Next slide, please. So in low middle income countries, there are specific challenges in regards that much of the information on causes of death are unknown, as many deaths occur in the community without a physician to assign a cause of death. And this means that the government are making decisions based on very little information and on a small number of the population. And that is not representative of the entire population, since the characteristics of those that die in the hospitals may be different from those that die in the community. And this is where a cost-effective tool like verbal autopsy can provide a valid and reliable information on causes of death at the community level. Next slide, please. So this graph concerns low and middle income countries, and it presents the proportion of deaths happening outside the health facility, estimated to be 90% of the data that is not captured and cannot be used for public health interventions, where only 10% of the data happen inside the health facilities and is captured and can be used for public health interventions, programs, and so on. Ahmed, next.
Thank you so much, Ahsan. Great. So we have a better understanding at this point of what CRVS is, and it's really this thing, at least during my education, that I took for granted. You know, living in high-income country as the U.S., it's something that we take for granted that all the information that's the other data that we get from CRVS just occurs. But that's not really the case in most of the rest of the world, namely the low and middle income countries. And as Ahsan mentioned, we can use verbal autopsy as a way of collecting mortality surveillance data. And as you can see from the name, it's a play on autopsies, but the verbal qualifier is important because there are no physical autopsies done, but it's a way of us being able to ascertain causes of death. So let's see what verbal autopsy is and how we use it. So essentially, verbal autopsy is a tool for determining the causes of death and the cause-specific mortality percentages in populations with both incomplete CRVS, meaning we only get some of the data that we've mentioned, or non-existent CRVS. And we'll give an example of that in a little bit of our own work. And what it consists of is training community healthcare workers to go out into the field and interview the families of the deceased, right? And by deceased, we mean those who have passed away outside of the healthcare system. And this usually occurs between 1 year to 3 months of the death. And what's really exciting about verbal autopsy, I mean, yes, the fact that we can get the cause of death information after the passing away of the individual, but also is that according to research, it's actually been shown to outperform physicians in providing accurate cause of death diagnoses, which has been shown, this has been done on physicians in low middle income countries. But it's also great because there's really no compromise in the quality of the data that you get using verbal autopsy. So just because physicians are not available to be able to actually ascertain the causes of death in those regions does not mean that the quality of the data that we get from verbal autopsy is any less accurate or reliable. So we've mentioned that verbal autopsy is essentially a tool that includes an interview, right? And the interview is based on a standardized questionnaire that is produced, we'll talk about it, but from different organizations, and there are different versions of the questionnaire, but all of them have these components, right? So these questions include questions on injuries and accidents that may have directly led to the death of the deceased person, including questions on the signs and symptoms of the person during the period that led to their death. So for example, if I'm the community healthcare worker and I'm asking the mother of her child that passed away, I was like, well, did your child have diarrhea? Did they have a fever? Did they have a cough? So on and so forth. That is all part of the signs and symptoms section. There are also questions regarding healthcare use and outcomes. For example, have the recently deceased, have they seen a doctor? Have they been in a healthcare facility? Have they gone certain treatments? That is all information that is helpful in ascertaining causes of death, as well as there's an examination of any medical records or death certificates that may be available, which is usually not the case in some of these regions, but if it is, it can be a very important data point. And on top of that, because of these questions, they're essentially multiple choice questions. Did they have this or that, yes or no? This or that, yes or no? There's also an open section where we're able to just get the respondents' own words about what happened, which really helps us get a fuller understanding of the events leading up to the death. Okay, so just to recap, we have CRVS, and a crucial part of the goal of CRVS is mortality surveillance. And in places where we can't have mortality surveillance or there's incomplete mortality surveillance, we can use verbal autopsy, which is this tool where we conduct interviews essentially with those who know the deceased well. But I think before moving forward, it's important to kind of have a little bit of background into how verbal autopsy came about and how reporting of deaths is normally done. And so in regions in the world with functioning healthcare systems, Usually somebody who is terminally ill or who has passed away is seen in a hospital. The treating physician is the one responsible for ascertaining their cause of death and producing a death certificate. So this is normally how the process works in regions with functioning healthcare facilities. However, we're not talking about that today, and we're talking about verbal autopsy and its use. And so because many people in low middle income countries die outside of hospitals or healthcare facilities, we can use verbal autopsy to ascertain that cause of death after the person has died. And it's important to note that while we are using and talking about verbal autopsy within the context of incomplete CRVS or non-existent CRVS, even in places where people do pass away in a hospital, sometimes the information that we get at that time of death is not complete, and there's still some pieces of information that are missing. And even then, verbal autopsy can be used to supplement that information. But that's just one use of verbal autopsy. Okay, so I really like this picture. I've seen it as a medical student before, and I was asked, well, what are the first things that come to mind? But over the years and after our work with mortality surveillance and verbal autopsy, I think it's great because it really helps encapsulate the spirit of verbal autopsy and mortality surveillance, because it's this romanticized notion of the doctor, right? In the olden days, when somebody's sick or they've passed away, they essentially go to their home and they try to provide treatment in their last couple hours or days, or if they've passed away, they try to come up with what cause of death was, right? And this is really the spirit of verbal autopsy. Now, verbal autopsy as an idea, it may be recent in the past couple of decades, but the spirit of it has been around for over 100 years. And so going back to the 19th century, we had what are called death searchers. And essentially, these are people, not necessarily with medical training, that would go to the houses of those who've passed away and try to assess the nature of the death. And so kind of moving forward, there was this need for what is called lay reporting, especially in low and middle income countries. These death searchers, ideally, they were physicians, people with medical training, in order to ascertain these causes of death. But in places without medical capacity, meaning there's just not enough doctors to go around, there was a reliance on lay reporting. Essentially, people who don't necessarily have medical training, but have been trained enough to know what questions to ask and what things to look for, and to relay that information later on to those with the training. And then after some time, places with medical capacity started moving more and more towards physicians, towards people with medical training. But over time, in areas without that medical capacity, they couldn't do that. But it wasn't until really the 50s and 60s in Asia and Africa that there was more reliance on physicians as capacity was being built more and more. And just as a note, the term verbal autopsy was first coined in the Narongwal Project, which is a project in 1978 looking into mortality surveillance. So verbal autopsy was first documented in a publication in 1956 by Dr. Yves Barad. That's kind of when it started coming into the literature more. And it wasn't until the 70s that the WHO really started coming into the picture, where they started encouraging lay reporting of health information by people with no medical training. Again, this kind of encouragement, so to speak, was because of the realization that there's just so many deaths that go unregistered for us to just rely on those with medical training. And so we needed the help of those with without medical training necessarily, but can have other kind of training. And as I mentioned, these verbal autopsy interviews are based on questions based on certain questionnaires that have been developed by different entities, the two most popular being the WHO, the World Health Organization, as well as the Institute for Health Metrics and Evaluation. So while we love verbal autopsy, if you couldn't tell, but it's important to realize what you want and whether verbal autopsy is going to get you there, right? You want to make sure that you understand the uses of verbal autopsy to help you get what you really want. And so the first use, which has been actually the most popular use over time, has been as a research tool. So we could use verbal autopsy in the context of longitudinal population studies, intervention and research, and epidemiological studies. And interestingly enough, that's actually how we've been introduced to verbal autopsy through our research at Yale. However, that wasn't enough for us. We really didn't want the work to just end at a publication. We wanted to look at the implementation side of verbal autopsy, which is now becoming the more popular use of verbal autopsy as a source of cause of death data. And essentially, what differentiates that from just a research tool is that we can now use this information, this cause of death information, to be able to base policy, planning, priority setting, and benchmarking. In essence, we're able to use this information to develop new public health initiatives. And the great thing is that, okay, great. So I've used verbal autopsy. I understand, for example, now that in my region, COVID-19 deaths are the highest causes of death, right? And I implement a vaccination program. Well, I want to know if this vaccination program is actually having an effect. Well, I can use verbal autopsy to be able to monitor the progress and evaluation of said intervention. Okay, so now we know verbal autopsy, we know the uses, and we keep on talking about causes of death, right? So what are those causes of death? And again, it's important to know what causes of death verbal autopsy can ascertain, because if you're interested in Lewy body dementia, right, a type of dementia in the brain that can only be ascertained through an actual autopsy through slices of the brain itself, well, you're out of luck because you can't ascertain that from the questions from verbal autopsy. So it's important to know what you're looking for and how verbal autopsy can help you. So essentially, when we take this data and we run it through the machine learning algorithm, it produces causes of death within 12 categories. And it's important to note that not all causes of death can be ascertained. Only those that can be ascertained with a high sensitivity and specificity, usually over 90%, are the ones that are actually analyzed in the program. And even within those that are analyzed, not all causes of death perform equally well. So some are in the high 90%, some are in the low 90%, but still reliable enough to be able to base some kind of policy decision on. Okay, so there's a lot of information. Don't worry about that. I just want to show you the types of categories and the types of diseases or causes of death that can be ascertained within each one. So the first one is infectious and parasitic diseases. You have things like sepsis, HIV/AIDS, malaria, measles, and in purple here, which is very recent, is COVID-19. And you'll notice that within each of these categories, there are specific causes of death. So for example, we have measles or malaria or tetanus, right? That's within infectious disease. But if the algorithm feels that the cause of death is of an infectious nature, but does not neatly fit into any one of these, it'll show all the way on the bottom here, unspecified infectious disease. Or if it is of a cardiovascular nature, it'll say unspecified or other cardiovascular disease. If it can't exactly say, let's say stroke or heart attack. But if it doesn't fit in any of these, well, then it'll just say other cause of death. So it just gives you that level of detail in order to just have that confidence. Okay, so let's move on. Neoplasms, you have oral, digestive, respiratory, breast neoplasms. Nutritional and endocrine disorders such as severe anemia, malnutrition, diabetes, disease of the circulatory system, heart attack, stroke, sickle cell. Respiratory disorders, COPD, chronic obstructive pulmonary disease, as well as asthma. Gastrointestinal disorders, acute abdomen, liver cirrhosis. Renal disorders, renal failure. Again, notice that for some categories, there are a lot of causes of death, and for others, there's only one or two. And again, because we are limited here by the questions, but for policy decision purposes, renal failure is good enough. You don't need to know the specific cause of renal failure to have an effect in public health. Mental nervous system disorders, such as epilepsy, pregnancy and childbirth, and this is a very big kind of category in low middle income countries, such as ectopic pregnancies, obstructed labor, anemias, ruptured uteri. Neonatal causes, pneumonia, sepsis, tetanus, prematurity, stillbirths, fresh or macerated stillbirths, as well as external causes of death, such as accidental falls, road traffic accidents, assaults, and all here highlighted in purple, which is what I was mentioning, cause of death unknown, right? It just does not fit into any of those categories. And it still gives you that information, gives you that transparency that it's not, trying to give you any cause of death that it cannot ascertain with a high specificity and sensitivity. Okay, great. So we did CRVS, verbal autopsy. We understand what verbal autopsy is as a tool for interviews. We understand its uses a little bit better, and the types of causes of disease. So now we want to talk about our organization, Make Deaths Count, as an example of how this work can be actually implemented on the ground, and not just talking about it in theory. And as I've mentioned earlier, this work really came from our research early on at Yale, where we worked with an organization to help develop a verbal autopsy project. But then we soon realized that this issue is actually worldwide, and that a lot more impact can be made if we actually develop an organization rather than just pursue it through a research route. And so just to give you the context for this inspiration, we realized that 50% of all the deaths worldwide are unregistered. Again, meaning we don't know what the causes of death are. And 90% of deaths in low and middle income countries occur outside of healthcare facilities and are thus unregistered. So that's just pointing back to the earlier diagram that Hassan was showing you with the big arrow coming down from all causes of death. And so, as public health professionals and future public health professionals, sometimes we take it for granted that we have data for different things that we work with, but if you don't even have this kind of data, you can't implement certain public health initiatives. And we've also realized that currently there's no entity that exists to address this issue in an easily and accessible manner. And hence that was kind of the inspiration behind our organization. And so just to give you a feel for what this need is, here is an orange bar in 2040, just showing you the total number of deaths worldwide, projected to be at 160 million. Half of that, about 80 million, is set to be the unregistered or unreported causes of death, right? And to kind of crystallize that a little bit, the population of Germany is about 80 million, about 83 million. And imagine the entire population of Germany, not that I'm picking on Germany, but imagine they all pass away and we don't know what the causes of death are annually. That's just to give you a sense of the magnitude of the issue. And so what is the solution, right? In our mind, it was to provide sort of consultation services to global decision makers in low and middle income countries for the following. One, to help develop mortality surveillance systems using verbal autopsy, which in turn will help guide these public health policy decisions, because now these policy decision makers have this data, for the ultimate goal of improving the health outcomes for the most marginalized communities globally. And again, this is important because those who are most affected by the lack of causes of death data or mortality data are those who are most marginalized in low and middle income countries. And so just to put it formally, in case, what do we do as Make Deaths Count or MDC? We partner with ministries of health and NGOs to implement a survey-based program, which is verbal autopsy, providing local stakeholders with easily accessible and actionable information using machine learning algorithms. And again, it's important that we stress the accessible and actionable, because when these decision makers, especially in these regions with very limited resources, they don't have the time to sit for hours looking through an Excel sheet and trying to understand the information. We want to help them get a snapshot of what the issue is in a very short period of time. And so we do this through consultation services. We work with our partners to help them develop these programs. We provide the training to the community healthcare workers and to our partners in order to do these interviews on the ground. We, of course, help with data analysis. So after our partners have collected this information, we then are able to analyze it and produce the causes of death data and provide that for them, as well as academic writing, right? So if there is an interest jointly to produce this information and publish it, we are able to use our connections with Yale to get this information out there in the academic world. And now I want to just give you a sense of how this information actually looks like, right? So this is just a mock-up of what the data dashboard looks like. And you can see here that we're able to provide data, or cause of death data rather, by gender, by location, by date, and on the right here by age. And even on the top here, it's just a snapshot of what is maybe of interest to our partners by COVID-19 cases or total cases. And so you can probably imagine how as somebody who doesn't have time, I can open this up and hopefully within 2 to 3 minutes, I can see, wow, okay, there's more causes of death due to what COVID-19, for example, in males versus females, or on this particular day, there was a spike in causes of death. So the information is easily accessible. We obviously provide information on cause of death by frequency. So in this case, COVID-19, for example. And we can also provide it by death heat map. So like if in this particular region, we found that the highest cause of death is due to heart attacks, well, I can see in a snapshot here that most heart attacks are occurring in this red region. What's going on? Well, now I have the data to ask these questions to perhaps develop new healthcare facilities in that region and so on and so forth. And I kind of want to talk about the impact here for a second, because it may not be self-evident why cause of death data is important, although we're hoping that at this point, you know, it's a little bit more clear why. But with our partners, specifically in low middle income countries, the efficient allocation of financial resources is of the utmost importance. They don't have that much money to go around, and they want to make sure that when they do spend it, it is giving them the most return in terms of the health in the community. And so you can have development of different public health initiatives based on this data. So as I mentioned earlier, let's say the highest causes of death in that region are due to COVID-19. Although, believe it or not, there are other infectious diseases that are still ongoing. So we can produce a vaccination program. Or let's say there's a high causes of death due to strokes. And with strokes, it's very important what we call the door-to-door time, the door from your house to the door to the hospital, in order to receive life-saving treatment. And so if that's the case, then maybe that'll help guide me in knowing where to develop the location of the new healthcare facility, right? Or if the likely causes of death are due to motor vehicle accidents, then maybe as a policy decision maker, I want to invest in civil infrastructure. Great. So now I'd like to send it over to Hassan to talk about our work a little bit to help crystallize all of this experience.
All right, thank you, Ahmed. So like Ahmed said, our very first initiative to produce mortality surveillance through wearable autopsy was in Northwest Syria. And it's actually started when a Syrian nonprofit organization operating in Turkey with the name of Health Information System approached Dr. Kavi Khoshnood, a professor in Yale School of Public Health, and us who were working with him at the time. And that is to develop mortality surveillance system in Northwest Syria. And it's a place with no governmental control and no means to capture mortality data on the community level. And their chosen methodology to do that is through verbal autopsy. Next, please. So let me walk you through the journey of this project. The first step was to select the tool or the survey tool for verbal autopsy. And at that time, we were debating between two tools. The first one was the WHO 2016 VA tool, which was comprehensive, but unfortunately, it was not user-friendly as it required an average time from 45 minutes till 1 hour to conduct a single interview. And the other tool was the IHME tool, which was more user-friendly as it actually required only from 15 to 20 minutes to conduct a single interview. But unfortunately, it did not have COVID-19 among the list of causes of death it screened for. And at that time, we went through like research studies and published papers to see if there are any papers that incorporated COVID-19 into the IHME tool. And we also contacted Dr. Abraham Flaxman, which was one of the professors who introduced the tool. But all this did not help us actually to overcome this challenge. But during the time the WHO published their newly updated 2022 VA survey tool, and it was more valid and reliable, and they incorporated all the lessons learned from the previously published versions of the VA tools. And it was also more user-friendly as it required from 25 minutes to 30 minutes to conduct the interview. After deciding on the VA tool, then we spent almost 2 months compiling training material from different resources for interviewers who are the individuals conducting the survey, and the supervisors who are the individuals providing oversight and technical assistance. After that, we had another debate about the sample size and the sampling methodology. And even though cluster sampling is the best methodology to be used, we agreed on a convenient sampling methodology, which was the best methodology for the Syrian context. And for the sample size, we agreed first that we're going to conduct 25 interviews just to test how does community health workers can use the survey, if they have any further training needs, or if there were any challenges that we did not account for. And for the pilot phase, we decided on a 600 interview for the sample size. Then to allocate death cases, we had to identify the most appropriate reporting strategy in the Syrian context. And it was decided that it will be through the community leaders in each region within the northwestern Syrian context. And the flow of information was going to be from that the community leader is going to allocate the household with a death case, and then he or she is going to report that to the supervisor. The supervisor is going to map out the household locations and will schedule the visits for the interviewers accordingly. Then after that, we had to identify the community health workers who are the interviewers, and they ideally should be a non-physicians and a trusted members of the prospective community. And in this regard, we collaborated with another nonprofit organization operating in Northwest Syria, and they were the physician across continents. And the organization already had several community health workers operating for them on another project in the same region. After defining the main structural elements, we applied for several grants, and successfully we won a $150,000 grant from the Bloomberg Vital Statistics to implement the pilot phase of the project. Directly after that, we started for the first step of implementation when we traveled to Gaziantep in Turkey on the Syrian borders to deliver a 4-day training sessions in person to the supervisors, who in turn delivered the training virtually to the interviewers in Syria. The training included discussions on CRVS, the causes of death, coding, ethical training, sensitivity training, interviewers and supervisors' role, quality control of the interview, possible challenges, role play. So we delivered that in both theoretical and practical lens. And directly after that, the interview process started. And so far, the Syrian team reached 450 plus interviews out of the targeted 600 sample size. Next slide, please. So through this journey, we encountered several challenges. One of the challenges is that there was no specified, simple, evident, and user-friendly training material available for verbal autopsy. So in order to prepare our material, we had to go through numerous scattered resources to come up with a 1 4-day simple training module that provide training for both a practical and theoretical lens. The other challenge was language barrier and cultural sensitivity. So the WHO VA survey was only published in English, so we had to translate the survey to Arabic, and we had to remove some of the culturally inappropriate questions. And we did that after several consultations with the WHO. We had several meetings with them just to make sure that we're not messing with the algorithm or the validity of the tool. Another challenge was the cultural aspect in the Northwest Syria, as it did not accept an interview to be conducted with a female through a male interviewer. So to overcome this barrier, we agreed to send both a male and a female paired together to each household instead of the recommended one interviewer per death case. And another challenge was to preserve the confidentiality of the deceased and the interviewee. And as in order to do that, the interview process should be done in a quiet and a separate room if possible. However, some of the interviews were scheduled to be done in camps where confidentiality is very hard to attain. And so the team decided to dedicate a separate tent for interviews to try to preserve the confidentiality of the interview process whenever possible. Next, please. So the key element to overcome or reduce the impact of all the challenges was to rely on our partners, as they are the ones who knows best what are the facilitators and the hindering factors that might challenge the success of our project. Next slide, please. So this experience inspired us to mimic this project in other regions of the world in dire need of such initiatives. And currently we have an agreement and active discussions with organizations from Somalia, Colombia, and India, and they are very enthusiastic about this project. Next slide, please. Another project that we are working on currently is social autopsy. And social autopsy is a related method that focuses on social and health systems determinants of outcomes, providing supplementary information to that on medical causes of death. A combination of VA and SA can assist in identifying gaps in vital statistics, facilitating benchmarking, and planning, all to improve the health system into functioning more effectively. So social autopsy provides you with the social determinants of health that we know, plus the medical cause of death that we are able to find out with the VA. Both SA and VA provide us with a holistic point of view on the death case. And we are currently collaborating with someone from India who had her PhD in social autopsy to help us develop and validate a social autopsy survey tool that we're going to use alongside the VA. Next slide, please. So this is my teammate and I with our inspiration to help countries in need to develop a CRVS system. And next slide, please. So if you'd like to know more information about our organization, we urge you to visit our website or LinkedIn page, or please feel free to email any of us on the mentioned emails here. And thank you very much for listening and for your time. And we are open for any questions that you might have. Thank you.
Thank you so much. Thank you, Ahmed and Hassan. I mean, this is fascinating to do this with that age. I mean, the sky has no limit. If you guys, I know not all of you are interested in global health. Some of you may be taking this class because it's required. But what I want to say, what you can do is amazing. You don't have to be in high like a stakeholder to do change in the world. Sometimes things come as a seed from students, from collaborations, and trust me, people are willing to help. So the PowerPoint slides will be uploaded to Blackboard. If you guys want to contact them and see how you can they contact you, like to see if they can help or learn more about your work and be part of this amazing project? Yes.
Yes, yeah, I didn't know what the question was, but yes.
Okay, okay. Okay, so now I'll open the floor. We have, I think, 5 more minutes if you guys have any questions for them.
No.
Thoughts, comments, questions. Open the floor.
Things you didn't like. We're more than happy to.
I have a question.
Yes, hello.
So like in these low to middle income countries where they don't have like technology to like store records, how hard is it to like, first of all, modify the like civil laws, modify the ways of intake and storing and like upkeep of the records? Like, how do you do that in the long term to make sure it's maintained?
Wonderful question. It's really the $1 million question. I think the best way of putting it is that our role really ends at providing the data. We understand the importance of having the data, but we know our limitations. We're not going to go into these politically difficult climates and change how things are done. But what we are hoping to do is, by working in these different regions and providing this sort of proof of concept, the first project, so to speak, and hopefully when it shows its success, it can then be taken up by the Ministry of Health and integrated into their own system. Because again, our goal is not to keep doing this work year after year in those places. We're just a stepping stone in hopes for the governments there, the ministries of health there, to be able to take up this verbal autopsy as part of their day-to-day work. Hopefully that answered your question, but I think it's it's too difficult for us to really go in and change practices in that sense. But that's why we're really relying on our local partners on the ground to be able to spearhead this.
Thank you.
You're welcome. Has anybody heard of CRVS, just out of curiosity, or verbal autopsy before?
We didn't touch, we'll talk about data and evidence-based data in the next couple of classes.
Okay,
And we'll also introduce the SDGs that you guys touch base on, rule of WHO. This is their second class in this semester. So the first class was only an intro. So that's why like many of the things you throw on the PowerPoint, you guys might think, what is this? We'll talk about whatever they talked about, those terminology. But I just wanted to introduce your work to them. I met Ahmed in the IPHA in November. And this is how I knew, I never knew them before. So we have, we provide like Study USA, Dr. Hannah Allen, she takes students to the APHA, or even if you guys have a thought of a project or something you want to present, it's a very cool place to meet amazing people, like-minded people. And from there, you can start like a career opportunity or a research opportunity or so on and so forth. So yeah, just wanted to say that. One last question? We have time for one last question. No?
Okay.
I mean, I'll upload PowerPoint slides to Blackboard. If you guys think about a question later on, feel free to shoot them an email.
Yeah, sure, absolutely.
Absolutely, yeah, we'd love to hear from you, anything at all.
I just wanted to say thank you so much, Ahmed and Hassan. I know you're super busy. Thank you for your present. It was amazing, and the work that you are doing. All the best. I'm trying to find connections in Iraq because this is where I belong, to have something like this in the Western Iraq where ISIS hit and we don't have much of records there. I'm trying to find like collaborations there, and hopefully we can find like a way to collaborate. Thank you so much.
Thank you. Thank you very much, Dr. Roa.
Thank you, everyone.
Thank you,
Thank
guys.
you. Enjoy the rest of your day. Bye.
And I'll share the recording with you later, guys. Thank you.
Thank you. Thank you
Thank
very
you.
much.
Take care.
Have a great day. Bye-bye.
You too. Bye.